We need to be ensuring swifter, simpler setup of clinical trials through to the agile regulation of medicines for UK patients. Fast, streamlined, standardised contracting framework is really central to the UK's aspirations to be a leading destination for clinical research. But actually the current reality is quite different, and the clinical trial environment in the UK is actually currently is deteriorating.
Good evening, everybody. My name is James O'Shaughnessy, and on behalf of myself and Professor Mike Bewick, who is joining us online, my co-chair of the Life Science Commission, I want to welcome you to the launch of our report, the Commission's findings for 2022. It has been a fantastically interesting piece of work for us, the commissioners, and I hope it will be for everybody who reads it. And I want to thank everyone who has joined us tonight in person as well as online for their contributions to the report. It is the work of many people. And as you will see, we have a star speaker this evening, who is Steve Brine MP, who Steve apparently, can you hear me?
Yes, I can.
You can hear it. Brilliant. Excellent. I'm going to introduce you in just a mo, if I may. Just want to say a few quick words of thanks before we pass over to Steve. Steve, as I'm sure everybody knows, is chair of the Health and Care Select Committee in the House of Commons. Those thanks go to Curia and Chamber for putting on not just tonight, but the whole work of the Commission, for being our secretariat, to our sponsors IQVIA, Eli Lilly and Bearing Point, to my fellow Commission members, Professor Gillian Leng, Dr. Keith Ridge, Richard Stubbs, Dr. Harpreet Sood, Neelam Patel and Corinna Bull, and to our advisory group and to everybody who contributed to our inquiries, both in person, on Zoom and through the case studies and other contributions. We have a lot to get through tonight, including an introduction to the report, but we also have Steve with us until he votes in about 17 minutes. And so I'm going to hand over to you, Steve, to talk about the work that you're doing through the committee this year and the year ahead. So over to you.
Thank you very much, my lord, or as I used to call you, neighbour. James and I were neighbours when we were health ministers together at the Department of Health. It's a great pleasure to be with you, James. And it's rather ironic that given the snow and the pending train strikes, I managed to get really smoothly from Hampshire to Westminster, and yet I can't get across the Parliament Square to see you in person, because we are, exactly as you say, about to vote in 17 minutes, just to be precise. And when you're a former whip, it's quite hard to ignore the whip's advice. So it's a real pleasure to come and speak at your event. I look forward to hearing what I can before I do vote, and then reviewing what you say. I mean, the Commission's obviously been doing some very valuable work, James, to bring together a series of pretty exciting findings for the NHS and the life sciences industry. I know it's a subject for which you get out of bed easily every morning. I would say there's a lot of synergy between the work of the Commission and the work of the Health and Social Care Select Committee, which I have obviously now the privilege of chairing since I was elected by the whole House back in November. It's no secret to anyone that my priorities as chair are cancer, and prevention. I made this clear in my pitch when I stood for chair, and I've reiterated it many times since. There are two subjects about which I feel very strongly, both from my previous experience in government as a public health minister with yourself, James, and from my own, sadly, personal experiences. It's been a hugely busy time for the committee, and things are going to get very much busier over coming months, seeing as it is the number one issue on the agenda. And I'd say that health innovation is very much at the heart of our current inquiries. So one of our two main inquiries, which I've inherited from Jeremy Hunt and I've decided to continue, is digital transformation in the NHS. So this inquiry is exploring the use of digital technology, examining how it needs to change in order to deliver an improvement in services and outcomes, stress that for patients. We're looking at the key aspects of NHS digital transformation, such as digitalising health and care records, so they can be accessed across primary, secondary and social care. And by primary, I mean pharmacy as much as I mean general practice. It's also looking at legacy IT systems in the NHS, yikes, and the interaction between digital transformation and clinical research. We're going to be looking at how to prevent digital health inequalities and inform patients of the potential benefits of digital approaches to healthcare. And when we return in January, we're going to be looking at our next stage in this inquiry at the NHS app, which I think has wonderfully great potential. Let's face it, most of us had it because it had a COVID passport on it, but it is going to really come into its own in the years ahead. So we've already heard in the digital transformation inquiry some pretty interesting developments. It's clear to us that remote monitoring and care for some conditions, long-term conditions, proved essential to enabling people to manage their health effectively during the pandemic, and then therefore minimizing the need for in-person appointments. And that is one legacy of the pandemic that I want to see continue. So we've already heard that these products and services have got an important role to play in long term in reducing the need for face-to-face service and appointments, which obviously can be time-consuming, expensive, and actually just not the way that some people, and I stress that, some people want to manage their own health. We heard in the inquiry already, for example, about innovative projects such as the Cystic Fibrosis Trust Breathe project, which uses an app to collect and monitor health measurements from patients, as well as then allowing them to monitor their own health from home and potentially avoid having to visit a healthcare setting for their routine monitoring. This potentially has much wider benefits. For example, the project is investigating whether it's possible to predict when someone's likely to have a flare-up of symptoms, often days before they start to feel unwell, which could have major implications for the way that condition is managed. We've also heard about how the health service is driving and funding innovation. For example, NHS's AI and Health and Care Award funding of £10 million over 3 years has allowed one health tech company, healthy.io, check them out if you don't know them, they're excellent, to develop a product that enables a smartphone to undertake urinalysis, demonstrating kidney health in people with type 2 diabetes, that is. We reckon that's enabled just short of 100,000 people to home assess in the past year. This is good. This is excellent. So as part of this inquiry, the committee is hearing how virtual services can sometimes offer a more efficient, convenient alternative to physical services. We heard from an online pharmacy. James, you remember my passion for pharmacy. Pharmacy to You, working alongside the NHS, that dispenses about 1.5 million NHS repeat prescriptions per month direct to people's homes. And that's the equivalent of around 200 brick and mortar pharmacies. Not that I don't, before anyone gets excited, not that I don't think they're critical, and they are a critical part of primary care, or pre-primary care, as I always call it. But we have to recognise that that is a service that people want, and the demand is clearly there. I think it's also interesting to find out how data captured via digital services is being used to gather and then produce information that can contribute to better planning for healthcare delivery and wider population health management, and for then use in research and innovation. So the inquiry is currently midway through its oral evidence programme. I'm sure there's lots more exciting innovations to hear about before we produce our report. And that report will make recommendations to the government, and the government will then respond to us, we hope, quicker than they have on some of our previous inquiries. So the division bell, as you can hear, is going here in the House of Commons. So I will have to go and vote, but I just wanted to say, because I have 8 minutes, as those of you who were MPs will know, we're going to be looking at the digital stuff and finishing that. We're also going to be looking at a big prevention inquiry, which is going to be starting in the new year, and something I call future cancer. I think you'll be very excited by some of the work we're doing on future cancer, James. So at the moment, obviously, we try and diagnose early, and that's clearly critical because early diagnosis is cancer's magic key. But that's symptom-led early diagnosis. We do now have the ability to get upstream of that, and if we can do that, I think we can save many, many more lives. There are big ethical questions that it raises for obvious reasons. But I think future cancer around detection, future cancer around then treatment. So what is the future of precision medicine? What is the future of proton beam therapy? We're going to be looking at all of that in our future cancer report. I think you'll find the work that we're doing next year will have a lot of synergy with the work that you're doing, and I really hope that, James, we can stay in touch. Maybe you'll come and give evidence to us, because I think that there'll be a lot of synergy between that. And it's very, very clear to me that overall health innovation is absolutely crucial building block of a functioning National Health Service. And that's why the work that you're doing in the Commission is so important. It's why my committee will be considering health innovation in so many aspects of its work in 2023 and beyond. And with that, I'd better go vote.
Thank you so much for joining us. That was a brilliant tour d'horizon of the work of the committee, and I'm thrilled to say that there is a huge overlap between ourselves and the work of Commission, not just the work we've done this year, which you've seen, but in terms of our planning for next year. We would love to come and see you in person and in the committee, and to do what we can to contribute to those important programmes of work. So Steve, thanks so much. We'll let you go. And have a happy Christmas if I didn't see you before.
And you, and of course, anyone who, is listening as part of the event this evening in person or virtually, who wishes to get involved in our inquiries, it's all online. We have big outreach programs around the prevention inquiry, particularly to help us scope it out instead of just us deciding what we're going to look at. So please get involved. We've had 14,000 replies already to our call for evidence on our assisted dying, assisted suicide inquiry. So the staff are going to be busy, but I'll let them have Christmas Day off.
So I think you'll agree that was a brilliant way to start the discussion. We know what the political agenda of the committee is going to be, on top of the agendas of the government, the opposition, and others. So it does provide a perfect backdrop to the event and indeed to our report. In terms of the event itself, Mike and I, hi Mike.
Hi there, how are you doing?
I'm going to introduce the report together, double act. Hopefully that will work. I'm then going to hand over to Hamish Dibley, who's director of Bearing Point, and then we are going to move to our panel event, where it will be myself, Gillian, Leng, Richard Stubbs, so both from the Commission, Laura Lane, who I'm delighted has joined us in person. Laura,
hello,
good to see you. And Ben Bridgewater, who is the CEO of Health Innovation Manchester, who will be joining us online. So that is the agenda. Now about the content. What have we been up to? The group was really brought together and is motivated by what I describe as the sort of twin imperatives. The first is how to make the most of and amplify the UK's incredible strengths in life sciences, in discovery research, in health research, which is not just historic, it's going on today, amplified, I must say, by increasing investment as the UK moves to become a more R&D rich economy. And I think a source of agreement across all the political parties, across anybody who aspires to govern, whether they're political or in the civil service or elsewhere. We know we need to maximise the impact of this sector if we're going to build an economy for the future. In fact, I would go as far as to say it's impossible to envision a future economy for the UK that doesn't have life sciences and health technology at its core. And of course, we saw all of that on display to an extraordinary degree during the pandemic. And just to pick out three aspects, they're well known to you, but I think nevertheless worth dwelling on and certainly learning from. The recovery trial, the world's largest ever clinical trial, finding dexamethasone and trialing other therapies for the treatment of COVID before we had a vaccine, the development of the vaccine out of a university into a major UK headquartered pharmaceutical company and then into people's arms in less than a year, the deployment of the vaccine at scale, we take it for granted, but an extraordinary feat of logistics. And of course, the use of data to track disease, to manage what was, of course, an incredibly challenging time, not just in terms of healthcare services, but all across the economy. Those are three great strengths that we have in the country. And one of the things that we wanted to do was think about how we can make more of them. The second was inevitably to address some of the areas that are a bit weaker, some of the structural or historical challenges that we have. One of those, which we address explicitly, is how to drive uptake of the most significant health innovations. A story you will often hear from health innovators is that their product or service will get uptake in a handful of trusts or a handful of customers, but then it will get stuck. That is the word you hear a lot. So one of the things we were concerning ourselves with is how do we unstick the best innovations? But not just unstick them so that they can go to the people who arguably need them least, but actually so that they contribute to addressing the health inequalities that still bedevil the country. And as you'll see from the report, we really do focus on that at the beginning, because that is the burning platform. We had COVID was a burning platform. We have plenty of burning platforms if we really want to, if we really feel that we need them. and health inequalities and comparative outcomes to our peer group countries ought to be enough to encourage us to think radically about what's required. And in thinking about how we address those challenges, as I said, we want to think of it as the triple win for patients, obviously, for the economy, so it drives wealth as well as health, and I think for the taxpayer. We all understand that we are heavily taxed at the moment, and nevertheless we're in some difficult fiscal environment. And it's important to be realistic about that and think about how we can square that circle. So that's the sort of twin imperatives that we were focused on. And in doing our work, which Mike is going to explain shortly, we set ourselves the goal of creating impactful but practical recommendations that could be implemented at pace in a reasonable timeline. As again, you'll see from the report, we have imposed deadlines on every single one of our recommendations, not because we want to cause trouble, but because we want a sense of urgency. And we tried to be realistic about what could be achieved. And as I said, we took great care and have taken great care to make sure that we are pushing against the doors that we believe are open all across the economy, whatever political party, whatever part of the country, whichever government, UK, Scottish, Welsh, Northern Irish. Everybody wants to see the UK is not just a science superpower, but a life science superpower. We know how to do it. We know what our problems are. So it was just about rolling up our sleeves and trying to come up with some ideas. And in doing so, we were aided unbelievably well by everybody who contributed, as I mentioned, to the inquiry sessions we had. A few of those are in the room and online, to people who gave us case studies and other data. And I do want to reiterate my thanks to them. So Mike, I'm going to hand over to you at this point. You're going to talk us through the methodology, the subjects, and then some of the top line recommendations.
Thank you very much, James. And just to reiterate, and thanks to Chambers for organising this, and also for helping us for the best part of 7 months now, I think, James, we've been going on with this, which is, and we've been very, very lucky to have such great contributors to I'll go into in a second. When we sat down with this, we had to decide what our audience was and how we would, sort of look at the key areas that we felt were important. And listening to Steve Brine, I think we chose 4 areas that were important and will help that Health Select Committee in its inquiry into innovation. And we chose data. And I think we were very, very blessed in the sense that Ben and his report came out virtually just after we'd set up that first part of the commission. And so Ben Goldacre was incredibly helpful to us in looking at some of the recommendations that would, I think, dovetail in with his own paper and his own extensive research that had happened at that time. The second area is integration, which is the story of our time, really, as integrated care organisations come on stream and develop a maturity. And we were lucky there to have amazingly good contributors, both people who are actively involved in that and to some extent critiques of perhaps the areas where we haven't yet thought through what some of the outcomes will be of setting up those new organisations. And then, of course, as James has started to talk about earlier, which is around the clinical research agenda and how we build on what happened during the pandemic. And it's important to realise how significant that was. And when we looked at our audience, I think that orientated us. It's the audience that was successful during the pandemic. So industry, academia, NHS in both its providers and commissioners, policymakers, and service users, and how they're brought into that sort of co-design of clinical research. And you'll see in some of the recommendations about where we're looking at that sort of co-design, as well as some of the more prosaic areas of research that we need to concentrate. And then finally, scaling and how that the service takes the innovations that are really proving to be successful, and how we use the centre of both NHS England and social care to actually highlight that, and then in a democratic way, scale out into the periphery of our country. So to do that, we decided on an inquiry type approach in the same way as a Health Select Committee would work. And we had 4 2-hour sessions, each concentrating on the 4 areas that I've highlighted. And we were lucky to have very, very good commissioners. Professor Gillian Leng, Richard Stubbs, Neil Patel, Keith Ridge, and Harpreet Sood helped ourselves during that inquiry. And we split the 2-hour session into 2 into two sections so that we could get more and more subject matter experts into the room. And over the four areas that we did the commission, we had over 29 contributors to those four areas. And this produced, I think, a richness of the report, but also they were helpful to us, along with an advisory board that we had backing us up in honing in on what were the important recommendations. It's 5 years now since Sir John Bell's sent his life sciences report to government. During the pandemic, we certainly knew how to escalate that and certainly knew how to power it up so that we got rapid responses in terms of clinical research. But there's to some extent been some treading of water since then. And James, I think you highlight that perfectly, in the introduction, that we need to concentrate again and make this country into what it was during the pandemic, which was a powerhouse of research and innovation. So our recommendations, of which there are 20, roughly 5 for each domain. And I'm just going to highlight a few of those before I finish. The first is on data. And it's very easy to invest in the infrastructure, but it's sometimes easy to forget about the workforce and the digital literacy that is required for them to handle that data. So we're recommending, alongside the workforce review, that data enrichment in their education is at the heart of that. In integration, we really looked at the mobility of employment and this idea of the employment passports to facilitate staff working across the local system, irrespective of employer. And this comes to some of the heart of the ethical issues that I think Steve was coming to about how we share data. And looking at Ben's work, not just in the research element about how we safely share that data in terms of the trusted environments, but it's also about trusting how integration is going to bring together data sets and people's mobility across the service to make sure that wherever they work, they have access to the information they require. The clinical research area, we could have made 30, 40 recommendations, but I think we were trying to be concise. But as Steve mentioned in his opening remarks about the NHS app, we all have it now. Let you utilize it fully to make sure that people can register for clinical research projects. And our aim is to get 50% of people to be accessible when clinical research and clinical trials can be further developed in the communities. And this should be done, we think, fairly speedily to maintain the momentum that we had during the pandemic, so that all those people who volunteered to be part of research projects during that time are not lost, and that we actually enhance that as time goes on. And finally, NHS England for scaling. Ian Dodd was a major contributor to our scaling debate. And I see Ben's on the line as well, Ben Bridgewater. And we had an amazing debate about what can be done in this one. But then boiling the ocean is also a difficult thing to do. So perhaps we have to be much more focused about that. So we were looking at how the system might help the most. And one of those areas is reimbursing pathways for digital health and technologies in the same way that we do for medicines. And I think if we can get that right, then I think the technology side of this, as well as the pharma side of this, will actually thrive and help us in that amazing innovation that we need. So my final point is this has been an incredible thing to be part of. And I think the reason for that is the number of contributors that we've had that are so positive about the future. What they want is the infrastructure and tools to make sure that happens. And I'll hand back over to you there, James.
Thank you, Mike, for fantastic exposition of the core recommendations and what we were trying to achieve. I think it's also worth saying in our work, this report is a milestone rather than an end point. We see this and hope this will be a continuing piece of work where we will continue to work with more and more and different bodies to develop both these themes and the future themes that we will announce shortly for 2023. So that engagement that we've been undertaking, that we've very privileged and humbled to get such a positive response on. We want to encourage that. So whether you're in the room here or in the room on Zoom, please do feel that this is an ongoing engagement, and this discussion will continue. And indeed, even the recommendations that we've made this time, we know they can be improved, and we want feedback on them too. So that's a summary of the report. Hopefully we'll have more chance to go into it. There's a few people clicking through and seeing what else is in there. Gives me great pleasure now to hand over to Hamish Dibley, who, as I said, is a director at Bearing Point, sponsor of the Commission. And Hamish, can I hand over to you to say a few words about the report?
Good evening, colleagues. I've got a few moments to make a few observations and comments on this important piece of work, but I'm going to start this evening with an apology. I was really hoping to be with you in person this evening, but a combination of the poor weather and points failures on my route into London, certainly this evening, has prevented me from being there in person. So, as I say, erstwhile apologies. On behalf of Bearing Point, we're incredibly proud to sponsor what we consider to be an important and timely inquiry into the NHS and life sciences, and in particular into the way the NHS operates, its current modus operandi, ways of working during an unprecedented period of organisational and operational, financial and strategic challenges, which we all know it faces now and into the foreseeable future. For me, the inquiry sessions and their corresponding and resulting recommendations represent an opportunity to reset in order to more intelligently respond to those challenges which I've talked about, which are both individual, organisational and systematic. For me, I think there are many commonalities across the four areas, but the things I would draw out from my observations of and contributions around health data, integration of care, is that, for the former, we need to be asking the right questions of existing data sets. And then for care integration, we must avoid boilerplate solutions and thinking that that's a panacea for the problems which we face. When it comes to clinical research and scaling up, the points and observations that really drew me were the recommendations around and observations on these workshops, that there are no one size fits all. And actually, we need to think about creating the regulatory environment that enables us to improve and scale beyond going and past prototyping and piloting. On that resetting point, I think the opportunity to progress via a more progressive path is already here. And through the contributions that we've made, both myself and Bearing Point, through our go-to-market opportunity around humanising healthcare, which is in the final report, or a case study of least is in the final report on pages 38 and 39. I'd encourage colleagues, friends, to read that, because I think it's entirely possible to achieve what I call the healthcare holy grail, which is better services at less cost. But it requires a reset in the way we think about understanding, managing and improving operational system performance genuinely through the lens of the people that we call patients. If you do that, when you think like this, you can achieve monumental results that span not only organizations, not only service area improvements, but also for the well-being that Steve Brine talked about, and wanting to create more preventative healthcare systems. I think the opportunity is monumental. And just to conclude, we are very, very proud to be part of this commission, and we'll hope to work with you guys in 2023 to progress further. Thank you.
Hamish, thank you very much. And again, sincere thanks to Bearing Point, to IQVIA and to Eli Lilly for your sponsorship of the Commission's work. Just one point I do want to pick up on that Hamish mentioned, which I think is important, which is the nature of the sort of innovation that is in the title of the Commission. Because it is easy to think of innovation just purely in terms of life sciences, you're thinking new molecules or a new algorithm. But we're really talking about changes of behavior and practice as well. And one of the things that we were very conscious of, and this was reflected in the people who contributed to the inquiries and sent us in reports as well, was trying to find ways to alleviate the extraordinary burden that healthcare professionals are under using innovation. That's actually and access to to new medicines and so on, which to the benefit of patients. That's actually what we're trying to do, that combination. And I think it is worth sort of putting that in lights as well, because all too often, I think there is a sense in which innovations are felt to be, perhaps by people working in the health and care services, as just one more thing that they've got to do. And if that is the case, then we do not have an innovative system. We cannot have an innovative system when we were just asking the impossible of people. So what we have tried to do, you'll be the judges of whether we framed it properly, but we've tried to frame these as innovations that can help improve productivity, actually ease some of the burden, improve services, better outcomes for patients, and to Hamish's point, to be able to do that at an increasingly affordable cost. So that will always continue to be a lodestar for us as we go ahead. So you've heard from our speakers. We are now going to move over to the panel session. Mike and I are going to do a bit of a double-hander here as well. I'm going to introduce the first 4 questions, which have all been submitted online. Mike will do the next 5. And then there'll be an opportunity to ask people in the room if there's any other subsequent questions before we wrap up. I'm now joined by all our panelists. Yes, excellent. Gillian, Leng, we've got Laura, we've got Richard, we've got Mike, and we've got Ben. That's everyone we're expecting, I think. Very good. So are you all ready? Primed? Good to go. Thank you for joining us. It's a delight to see you. Our first question is from Christina Farrow, who's Deputy Director for Innovation at NHS England. Does the panel think central/national support is needed for life sciences, or should it be a more locally driven approach? A very good question. So I am going to come, Laura, you're in the room. So if you don't mind, I'm going to give you the privilege of answering that first, and then I will go around the rest of our panelists.
Of course. It's a pleasure to be here. So yes, I'll have a crack at that one first. So we need to have both. I think that's the thing that is the main take home of this. But we know we need local partnership. We know that local organizations and providers understand the demography that they're supporting. We know that GPs understand their patient bases. But if we consider the life science vision to be a national mandate, it must have national backing and the commitment from all parties, from government, from the NHS and industry, to enable the sector to grow. But we can't achieve that vision without working together and collaborating. But the whole ecosystem has to be right here. And there must be a market for the innovation that we're all wanting to grow, and that the government has said on multiple occasions it wants. In order that and that means faster uptake from a regulatory standpoint, that means consistent uptake across the geographies, and it means treating medicines as an investment, but not just a cost to be managed. So we actually, as a country, invest less on medicines than other developed economies, 9% of the healthcare budget going on medicines compared to peer countries where it's in around of 14 to 18%. And that spend's not equitable. We have individual examples of, trusts withholding access to a nice approved product until that their budget is set. And people just a few miles down the road obviously have access. On top of that, we have the current pricing system paid for by industry that caps, which is there, it was a collaborative effort to also, cap the medicines bill, but that essentially the capping has reached a sort of escalated to unsustainable levels, 5% from 2021, 15% this year, rising to 30%. And essentially what this does is stifle that ecosystem, such that the innovation, it doesn't look like there is that ultimate need and want for innovation. And that's despite all the efforts of a country where, historically we have led in basic research, translational research, clinical research, and we punch above our weight from an innovation standpoint. But if the commercial environment means that this effort is at risk of not being accessible or enjoyed by the patients in this country, then that's a huge shame. And essentially, healthcare it's a global endeavor, as we saw very much through the COVID pandemic as well. And if as a country we're not at the top, of those sort of launches of those medicines, especially if we're really, doubling down on the innovation side of things, then, that is ultimately patients potentially missing out.
Thank you. Richard, if I could come to you next. You've got a regional role, obviously at Yorkshire and Humber, but also a national role. So you're well placed to give us a perspective on this balance.
Yeah, thank you, James. And hi, everyone. Apologies, like others, that trains have got in my way today. I agree with Laura. It has to be both for obvious reasons. But I think the critical thing we need to think about is what are the functions that need to be supported at a national level and what are the functions that need to be supported at a local level and why? If you think about life sciences and the number of front doors that exist in the NHS, we don't need them to be spending precious shoe leather, and particularly for smaller companies going around the NHS looking to try and get 200 different conversations and 200 different answers. There has to be something about our ability to simplify things for industry in particular, give them a single version of the truth, and I think where possible, give them a single indication of the NHS's appetite to adopt and spread the innovations that they provide. On the other hand, innovation adoption is a contact sport, and we don't have a particularly good track record of, dare I say, more top-down determinations of the specific innovations that need to be adopted at a local level. So I think there's something about allowing local decision-making about local needs, while at the same time ensuring that at a national level, we do our best to simplify what is an overly complex system.
Thanks, Richard. And as people will see in the report, we have addressed both those topics, both trying to simplify uptake nationally, but also providing some local accountability through the new integrated care systems for liaising with life sciences and other innovative industries, and actually taking responsibility for increasing the use of innovation, effective and cost-effective innovation at a regional level. Gillian, you led NICE for a long time, so you have a particular perspective on the national picture, but I'm sure you'll recognise some of what Laura has described as the blockers that now seem to exist at a local level too.
Indeed, yes, yeah. And I would agree that you need both. You need national support and you need a locally driven approach. And the things that you need to do nationally should be thought of quite carefully. Things like summarising the evidence, things like regulatory mechanisms, things like perhaps costing. We know that at a local level, it's really helpful if you work out the implementation pathway as best you can with a cost attached to it at a national level. But what can go badly wrong is when you've got a national organisation saying, this is really important, but it doesn't fit with the local priorities. So there does need to be a mechanism of picking up local priorities, working out what needs to be done nationally, and then letting the local system get on with putting it into practice, providing support as required, obviously, but it's getting the balance right. And I have been in the system long enough to see some great examples of NICE recommended products being implemented hugely successfully, and others less so. So it is getting the balance right. There's room and indeed need for both local and national.
Thanks, Gillian. Ben, Manchester has been taking the lead as a regional city for a long time, probably more so than anywhere else in the UK, about sort of pursuing its own path and trying to be pioneering. What are you doing up there about this sort of local and regional pull of innovation?
Yeah, thanks. I mean, I'd agree with the thoughts of the other panelists in there that clearly needs to be both here. I think where I'd possibly have a slightly different nuance on it is we say in my organisation, the problems are the problems. You know, there may be slightly different accent to the problems as you move around the place, but the problems are the problems. And if we can tackle the problems effectively in Greater Manchester, they'll be applicable to Tower Hamlets and Truro. They may have different accents, different nuance to it, but the problems are the problems. And it does seem to me, looking back on my time in the innovation space, that we try and do a lot of things. And some of those things we do well and some of those things we don't do so well. But if we did fewer things and we picked them really wisely, so they were the things which would have the biggest effect and you get the biggest bang for your buck from your innovation deployment, we'd be in a better place. So we've come to the agreement with our colleagues at the ICB, and this doesn't happen without having lots of conversations and getting to know people and understanding how you can challenge and having the deep conversations you require to get stuff done. That we want a relatively small number of innovation activities, but they play into the big ticket items and everybody lines up behind them and we drive those things through. And importantly, those things we need to understand, as Jill's rightly said, the total cost of ownership of deploying innovation. We need to understand the benefits of delivering those. We need to understand what are the key performance indicators so we can properly performance manage those through. And importantly, going back to some of the comments earlier, we need to ensure they address, not create inequalities. And as Richard rightly said, this is collaboration is a contact sport, innovation, collaboration is a contact sport, and you only get these things to happen by having lots and lots of conversations and testing it and build thinking, getting everybody aligned around these things. Where I think we need to be clear about this, and I think this sits at that interface between national and local. There have been situations when there's been a national initiative which something needs to happen, which has been driven down through innovation systems, but maybe that hasn't been shared in terms of the delivery systems. So it's not on the top of the agenda for everybody. NHS, for example, OLS, for example, the regional offices, the ICBs, AHSN networks who have a role in this thing. And when you don't have that alignment, it makes it incredibly hard to get stuff done. Yeah, no, very good point. And I think that we are a sort of disaggregated national system, if such a thing is possible. NHS is full of paradoxes, and that may be one of them. And of course, that alignment, I think, Ben, is the point that you're making there. There will always be national priorities, but they need to be flexible enough to accommodate local need, and that does vary, even if the same problems often crop up. So thank you to our participants for that, our panelists for that. Our next question is a simple one, and I'm going to ask our panelists for a simple and short answer. It's from Rachel Ligo, who has asked, what regulatory lever or mechanism would you like to see in the UK in the next 10 years? So I think this is in order to promote innovation. Richard, can I come to you first, and then I'll go to Jill, Ben, and Laura.
Yeah, thanks, James. I don't think mine should take 10 years, so I don't want to time frame it. I'd like to within. If you think about regulatory frameworks as trying to drive the behaviours we want to see, I would love to see something to challenge systems about how they steal with pride. We don't seem to reward that kind of behaviour when we think about how we regulate organisations around their innovation and research functions. So stealing with pride, please.
It's actually one of our core recommendations in the report, designing a comprehensive reimbursement pathway for digital health technologies similar to that for medicines. You know, it's not always instantaneous, as companies will know when NICE recommends a drug that they're put into practice, but it's reasonably clear what the pathway is. Everybody knows how it should work. It isn't the case for digital technologies, and there's lots of potential for digital out there. So I'd really like to see us crack that nut.
Thanks, Jill. And just to underline that one, digital technologies, or indeed any medical technology that goes through the NICE process and is demonstrated to be cost saving, I mean, it is the definition of shooting yourself in the foot not to adopt something that is going to save you money, let alone generate value. So yeah, very much echoed that one. Ben, Laura.
So I'm not sure I'm taking issue with you, James, but I'm not sure it is a simple question, and I'm not sure my answer is actually going to answer the simple question. But I think I'll maybe get away with it. What I'd like to see for all of these innovations that we're trying to take forward is an absolutely clear RACI matrix. And it's interesting, RACI matrix isn't necessarily the way we see things often in the NHS, but you're absolutely clear who's responsible, who's doing the work, who's accountable, who's the single person who's driving it forwards, who's contributing, who's informed, and we can make sure with absolute clarity on that, I think we can go a lot further up faster. You'll take a judgment about whether that is a regulatory thing to do, but I think you probably agree it's probably quite a good thing to do.
I do. That's a very good thing, and possibly not regulatory, but doesn't mean it's not important. Thanks, Ben. Laura.
So from a regulatory standpoint, industry, we want to be a partner for these streamlined pathways that embrace innovation. We need to be ensuring swifter, simpler setup of clinical trials through to the agile regulation of medicines for UK patients. Fast, streamlined, standardized contracting framework is really central to the UK's aspirations to be a leading destination for clinical research. But actually, the current reality is quite different, and the clinical trial environment is in the UK is actually currently is deteriorating. I mean, I'm not going to go. I know we're short on time. I'm not going to quote a whole set of stats, but just one which I think is worth bearing in mind is that between 2017 and 2021, the number of industry clinical trials initiated in the UK per year has fallen by 41%. That's impacting our global rankings in very significantly. But I think there are also two other things. So inequalities of healthcare access are still a major concern, because if you can't recruit the diverse participation for clinical trials recruitment, then you're not understanding how those medicines are going to best fit with those patients. And then actually above and beyond that, I think currently it's just the capacity challenges. The NHS is facing COVID backlog, but also the sort of current crisis. Basic care standards aren't there in terms of, ambulance access, getting access to a consultant appointment in months, if not years, then, how can you then, in a challenging environment, figure out the way to deliver the next generation of treatments for patients who, require a pathway change or a new treatment model or an advanced modality that is complicated and requires a lot of, a lot of effort on the side of clinicians and a lot of side on in manufacturing and all of that to be joined up. So I think, conscious that we want to be going in the right direction, but actually at this moment in time, it's a pretty stark environment out there.
Yeah, and you're right to raise it, because we can't gloss over the fact that despite the successes, say, around clinical trials during the pandemic, there has been a decline, and especially for I guess chronic conditions. So if COVID has been quick, that means everything else has been slow, a lot slower. Yeah. Thank you. Do we have Dimitri in the room? Dimitri. Thank you. We don't have an in-room mic, so if it's okay, I'm going to read out your question and you tell me if I've got it wrong. Is that okay? So Dimitri, research manager at Civica, thanks so much for coming to join us. Your question was, how do we improve technological adoption? So I think that's the critical word here, isn't it? Not innovation as such, but adoption in the NHS. Ben, can I come to you first on that one? And then Laura, and then Richard, and then Jill.
Thanks. It's a good question. And this is the kind of question that Richard and I spend most of our lives racking our brains trying to get a clear answer from these things. But I think I'm going to be a bit methodological, I think, to answer this question. So I think when we see a lot of tech and a lot of opportunities, but often it's not entirely clear what the problem is that we're trying to solve with the tech. And actually, it's not often we get presented with something which has got a really crisp problem statement, which explains this is the problem, this is the magnitude of the problem, this is its consequence, this is its implications. And it's quite easy to get people to align around a well-crafted problem statement. It's much harder to get people to align around a single solution. So I think it starts with a problem statement. And then when you've got over the problem statement, you've got everybody aligned around that, recognizing that adoption at scale of anything, any technology, be that a new drug or be that a new widget or app or whatever it happens to be, requires change management, and people need to change, processes need to change, culture needs to support that. You need to be supporting that with the right kind of tools, project management tools. So there's something very methodological in this, which we need to think about. And I think the other thing we need to think about is some of the language. So in my organization, we banned the word pilot. Pilot is a dirty word. We're not allowed to use it because pilot creates pilotitis, and pilotitis is not good for anybody. We've banned proof of concept unless it's used in very precise ways. And that's usually about things like integration or interoperability. But we like a proof of value. So if you've got a problem statement and you've delivered a proof of value when you've thought about the implications to people, process, culture, and the tools, then actually driving towards adoption at scale is not such a hard thing to do conceptually, but then you need to do all the heavy lifting that I think Richard's talked about in terms of connecting to the various different bits of the system, all who think they've got some ownership in this stuff. So I think those are the things that I would think about, more methodological than we normally think about it, I think, in terms of taking this stuff forward. Thanks, Ben.
I think that point is incredibly well made. A couple of weeks ago, I was in Israel and visited a couple of their hospital groups, Sheba Medical Center, Clalit, HMO, and Benson. And it's a highly innovative economy, of course. It's a startup nation, as they describe themselves. But one of the things that was really impressive was how much time the hospital groups and indeed the HMO spent on that point about developing problem statements. Because actually, if you develop a problem statement, the innovators know what to go after, and you've got a ready-made audience, rather than just yet another group of people who are trying to sell more stuff to people who don't think they need it. So really well put. Thank you for that, Laura, and then Richard and Jill.
So, I mean, from our perspective, just briefly on this, systems need to genuinely improve care and outcomes, and they need to save clinical time. I think those are the things that you kind of really need to keep in the back of our minds here. You also need the talent. So whether it's on the technology side or whether it's on the digital and data side, people who understand data, the data analysts, the data scientists, people who are expert in this. So I think that's a key thing, as well as is expanding the workforce to include some of these sort of newer roles. I mean, data scientists, it's a relatively new type of role, and making sure that those sorts of aspects are embedded, so that it's not just plugging something in, but actually it's part of the fabric.
Yep.
In the same way that many aspects, the same way that clinical care is there as well.
Yeah, no, thank you. And I think Mike mentioned it already, but Ben Goldacre spoke at our health data inquiry, and I think all of us on the panel, on the commission, I should say, were very enthusiastic supporters of both the Data Saves Lives strategy and Goldacre review. And we endorse those, and particularly this point about workforce, which Mike brought out. There are new types of role, new types of function, and making sure we staff those, that we actually prepared with the digital skills for everybody, so that where those innovations are digital or data in focus, that there is that capability there is going to be incredibly important going forward. Richard, then Jill.
Yeah, thank you, James. And a very similar point, I think. I mean, Ben's right. We spend a lot of our time grappling with this particular challenge, and there are short-term necessary things that you can do, I think. And then, but I more and more, I think more upstream. What are the long-term things that we need to do? And Ben talked about culture, so I won't talk about culture. But for me, there's something about capability, capacity, and expertise. And I think when you think about our current workforce and our future workforce, I challenge us to think, are we actually training our next generation of NHS staff to be equipped to do this job better than we are currently doing with our current generation? I think we're probably not. So why would we expect things to change in the future? And are we investing the right amount in that capability and capacity? For me, with our innovation and research ecosystem or pathway, we do an awful lot of great work in the discovery side. But then there's almost a big box with kind of like, and then magic will happen when it comes to the adoption piece. And we need to recognize that that is a huge box, which needs the right capability and capacity and expertise in order to really exploit true adoption in a sustainable way, I should say, as well.
Thanks, Richard. You're right. There is always a sense of, well, I've created this marvelous magical thing. It's going to sell itself. Not the case. Jill.
Great interest to me, this topic, and spent some time at NICE with a student from Harvard looking at how long it actually had taken some of the technologies that NICE had recommended to be adopted. And usually it's 5 to 10 years, sort of veering towards the 10 years. So there is more we can do here to improve things, definitely. It needs 3 key things, similar to what Richard's just said. It needs people to be motivated. So you need good leadership. You need a good, clear case of why these things will make a difference. You need opportunity, which I think translates to time and capacity. And if people are so busy, they're running to stand still, it's hard to do adoption as well. And you need capability. So you might need training. And the more complicated technologies are to put into practice, the more, say, you might need to change a pathway, the more you need some systematic approach. So sort of kind of echoing what Ben said, you do need to be systematic. You need a plan, you need a project manager, you need to allocate funding, and it will take time, but you can do it with that clear plan.
Thank you. Moving on to our next question, which is from Emma Reinhold. And please say is in the audience. Hi, Emma. Again, apologies for the lack of microphone, but you have asked a question about a topic, as I mentioned, very close to the hearts of everyone on the Commission, which is how we can enable better and affordable access to health data for researchers. And I guess you mean, what do you mean, researchers in the academic as well as sort of in industry, just the broad, in the broadest sense? Yeah. So perhaps I could come, Jill, to you first on this, and then Ben, and then Laura, and then Richard.
A great question, because it's really important that we make use of our health data. The question, I think, is for researchers, but at NICE, we also wrote it into the strategy that evaluators also use health data more. So in the report, there's a number of recommendations about things that will facilitate access, training, advice for commissioners, a guide for data controllers, which we've suggested NHS England produces. But if I had to focus on one thing, for me, there's a really important element about public trust, because we need to ensure that the public trust what we're going to do with the data, how it's going to be used, and that they are sure that it will bring benefits to the wider population. And we've seen in the past that failing to gain public support has been quite a barrier to taking this forward. So I think we need to really focus our efforts on the public as we take forward the other recommendations.
Yeah, thank you, Jill. And one of the recommendations in our report, and I think suppose by the obverse, is we've seen where it's done well, it does persuade people about the merits of health data usage, and they become enthusiastic proponents of it. So it's a discussion to be had with confidence, I think, because the benefits can be explained and they are so powerful. Richard, then Laura, then Ben.
So I was 23 with a full head of hair when I started trying to tackle this problem, and I'm now 24 and all my hair's fallen out. This is the hard one. And, you know, I've spent so much of my life trying to deal with this particular problem. We're still not really over the hump of it all. I can tell you what we've done in Greater Manchester, which might be interesting to people. So we invested pretty heavily in bringing together an integrated digital care record, and we accelerated that hugely through COVID. And that's because we had some of the permissions to do that through the COPI notice to enable us to bring that stuff together. So we now have 100%, or as near as 100% as you can imagine, well over 99.5% anyway, of all the citizens on the GM care record. That brings together primary care data, secondary care data, social care data. So it's got good stuff in it and complete coverage. And we've done all the right things technologically with that. We migrate a replica of that database onto an Azure cloud platform. It's anonymized or pseudonymized or patient identified, whatever you need for different purposes. But that was actually surprisingly hard, given the fact that there was a legal requirement to share with COPI. And I had to have one-to-one conversations with a whole bunch of data controllers who were asking questions around that and question the right to share. So this stuff only happens because you make it happen, and that can be really quite a lot of hard work and quite difficult. Anyway, we got over that particular hump, and we realized that we didn't want this just to work through the pandemic, but we wanted to make it sustainable. So we worked incredibly hard trying to set up the right kind of structures. And we've got quite an elaborate governance structure now for this, where basically what we have is we've separated an expert advisory group who know how to use the data from a separate group which actually acts on behalf of the data controllers. So that data controllership group has representatives from primary care, from the hospitals, from social care, patient representatives on there, and is well chaired by somebody who's kind of authoritative and able to do that. And then we've set up sort of access protocol things for that, which again are pretty complicated. And what we're doing now is we don't want to drive this so fast things get fractured, because what we want to do is have really compelling use cases which we take forward, agree the governance that we can do a particular project on them, get that project done, show the benefits back to the system, show that benefits with complete transparency, show that benefit back to the data controllers, demonstrate complete transparency in our kind of access logs into the environment where the data sits, and so on and so forth. And we're gradually building momentum in that way to create that virtuous cycle and that trust that Jill describes. But importantly, that's not just back to the patients, it's also to those data controllers, because a data controller can just get in the way, and each GP is in effect its own data controller. We have gone from having no integrated care data to integrated care data with a fairly big, high-profile set of research outputs coming from it over, the last 2 years, which we're proud of. A lot of the researchers are banging on my door saying, can we go farther? Can we go faster? Can we go deeper? And I'm saying, well, I think we need to take this at a relatively steady pace to create that virtuous cycle, because you can fracture these things. This has been quite a lot of hard work to establish all that stuff. We're delighted to be gradually building on top of that data different levels of complexity into the analytics environment in terms of using some of the really clever stuff that happens in our universities and universities more widely. And we've been fortunate to get some funding, relatively small funding in the first instance, for some of those trustworthy research environments now into that secure data environment. But there is something about building this up in a sequential way to get to that sustainable place that we want to get to.
Thanks, Ben. And I think there is a really good model there for acting at a regional level. And obviously, one of the big announcements recently was the secure data environment contracts and projects for the whole of England, which includes, of course, the Northwest as well as the rest of the country. And I'm sure there's a model there to build on. But maybe I'll have lost my hair by the time we can falsify this statement or not. But I'm quite excited about what those are going to do for research. So we shall see. Laura, then Richard.
Yeah, so I mean, we would totally agree with what Gillian and Ben had said, both on the public trust and transparency and security point. I think I would also add one other thing there, which is around consistency of data. We need to use data better. Data is one of the strongest tools that we have when we come to improving health and care within the country. And as a US company who's obviously got a large presence here in the UK, there's a lot of, we have done, there's research done in the US that shows when, for example, ethnicity is reported and made mandatory in research studies, those studies also show greater engagement from underserved populations. So back to what we were talking about in terms of actually engaging diverse populations and improving access to healthcare outcomes. So the lack of consistency around many NHS data sets, that comes back to the sort of consistency point as well, and actually how, for example, patient ethnicity is defined and reported in terms of what data is actually reported, recorded, and broken down, which covers the full gamut of ethnic groups into which identifiers can self-identify, and only by identifying that sort of scale and impact of those sort of current inequalities. Without, if you're not able to actually get that consistent, comparable, high quality data, it's very hard to then take that data and do anything with it. And again, I think seeing the outputs of the use of that data for public good in terms of being able to target medicines, in terms of being able to roll things out, then obviously that will hope feed in to the trust element where actually it's gone in and then you can see the benefit of it.
Yeah, it's a really good point. And actually you underline the fact that the best, richest and most interesting data on disease is precisely where the need is greatest for new therapies, devices, and so on. And that ought to be a circle we can square, as well as bringing more jobs, more activity, more economic activity, and so on to those kind of places. So point really well made. Richard.
Yeah, I won't go over what Laura just said. I thought it was absolutely brilliantly put and very much covering the points I was going to make. I suppose I'd just say, James, just to reiterate this point about trust. I would really like us, and this is wider than the NHS, we need to think about a societal conversation about the use of data, health data being a subset of that, and start to earn the trust of our population to be able to use it in a responsible way. And I think that's about having that conversation at a point before we need to use it. I think one of our previous problems has been that we've been too quick in terms of assuming trust and then having some kind of short deadline for people to be able to opt in or out. Yeah. I'd like us to have a societal conversation about what data is for and start to re-earn that trust before we start to use it.
Yeah, great point. Ben, did you want to come in?
Some of the, and this is building on points just made, but I think it's important. Some of the data that we sit on, quite frankly, isn't very good. And there's an art in terms of doing research on it, knowing what it's good for, how good it is, and when you can't use it because it's not good enough. So this is a bit of an art in the sort of data science bit of using routinely collected healthcare data. Where it gets incredibly exciting, and I think we've touched on this in the conversation, but I just want to call it out overtly, is when you start to properly transform care pathways, you generate data which has much higher velocity, much higher veracity, and much higher value. And so some of the stuff that we've been doing with a global medtech partner in terms of using data from implantable devices, beat by beat variation, to pick up deterioration in care, that's really high quality data. The sort of quality data that I bet my life on, almost literally, because of what it is, which is a very different kind of level of data from the stuff that we got from routinely coded data out of hospitals and so on and so forth. So I think there's something which plays into the kind of recommendations and inquiry about these digitally transformed care pathways, where we accept that would create data which is much, much higher value, which is probably where we will need to be put much more of efforts in the future than we've been thinking about in the past.
Yeah, very good point. Thanks, Ben. Right, I'm going to hand over to Mike now, who's going to field the next questions as we in the second half of the panelist session. Mike, over to you.
Thanks, James. And we move on into the latter part of this panel questions. And we're concentrating on the life sciences first here. It's an interesting first question that was submitted by Ahmed Sadani, who I believe is in the audience. And sorry I can't be there with you to see you, but thank you for your question. And I'll probably come to Laura first on this, and that's, what can industry do to support the NHS in reducing inequalities in healthcare across geographies and demographic groups?
Thanks, Michael. So I think I'm going to pitch in on this in terms of looking at some of the core 20+5 sort of agenda. So we welcome that, as an approach for, providing a targeted and clear focus for addressing inequalities at a regional and ICS level. And that's something we've also been focused on, from working with, decentralized clinical trials to diverse participation. I've mentioned some of those already. In terms of, addressing inequalities which result from someone's income, race, sex, hometown, they're a key component to how we think about medicine. And on top of that, you have education, you have privilege, and that all impacts your ability to seek healthcare and self-advocate for treatment. And inequalities play out in so many different ways. We have to start with how we design the trials and deliver our research to improve diverse participation in clinical trials, and decentralization and information are both critical there, because ultimately we need to ensure the populations in our trials represent the patients who are ultimately there to receive the medicine. There are so many sort of data points out there, but one, for example, is that your background influences your health and your outcomes. So an example, Black patients have a 28% higher cancer-specific mortality rate, but in lung cancer trials only make up 4% of clinical trial participation. Diabetes is 6 times more likely if you're of, say, South Asian descent, and nearly 80% of people living with autoimmune diseases are women. So we can't ignore those factors, and as we continue to sort of tackle some of the greatest health challenges of our time, these are all very much baked into how you think about when you're designing trials and when you're recruiting for trials. A specific local example here is that Lilly have worked together with experts across the NHS to create a charter for change in diabetes care that gave us real insights from inconsistently capturing ethnicity data, for example, to the sort of cultural, educational, religious barriers that are preventing people from seeking care in the first place. Now, that's great for us to do, and we have great partners at a local level we work with on that. But we don't want that to be restricted to those individual partners and patients in those specific geographies. This should be something that is rolled out and is accessible on a national level for patients up and down the country.
I'm just going to link this to the next question, because you brought in the core 20+5, Laura, there. And Mark Naraja from C2AI, hi Mark, how are you, has asked what is being done by life sciences to support that core 20+5 NHS England ambition. And perhaps I could ask Richard and then Ben to concentrate on that and how they're approaching the health inequalities. And then Jill, I'll ask you to perhaps come in as a summary at the end. So Richard first.
Thanks, Mike. very, very briefly, just to cover both of those questions, because you're right, they are related. On the first, certainly the word that I've been leading on, a passion of mine actually for the last 3 years have been around greater diversity within innovation and the business case for that. And part of that work has been about championing our innovators with diverse backgrounds, because actually it's amazing when you get on the hood of an innovation, how their lived experience informs the impacts and the outputs of a particular innovation when it comes to health inequalities. And I think we need to do more to recognise the kind of the A star plus that a diverse innovator comes when they bring that lived experience into their R&D, and how we often don't get it right when we don't have that input at the design stage. So I think that's one thing I'd say. On the core 20+5 piece, I mean, I've personally been very privileged to work very closely with Bola Olivari and her team around core 20+5, and the role that innovation and therefore life sciences can play in meeting the objectives, both of original core 20+5 and now, of course, we've launched our core 20+5 for children and young people. I think there's an awful lot already out there in the ecosystem that has not yet been aligned with how it contributes to core 20+5, but has a natural affinity with a lot of the particularly the clinical disease areas that core 20+5 seeks to target. So I think for me, there's already stuff that we're doing that we need to just bring to the surface, how ICBs in particular recognize that actually it's a secondary benefit of adoption, that it also brings a core 20+5 positive attribute to, and we need to do better to almost kite mark that. But I've found in my personal experience, life science and the companies that I work with have been incredibly excited about core 20+5 and very much want to see it as a collaboration between themselves and NHS England about how we go further faster.
Indeed, I think if you make them more and more aware of it, the more excited they get about the opportunities it brings. But Ben, how have you approached it up in Manchester?
I believe that we should be doing health innovation in the same way that you make software, in that you should be really clear about what the problem you're trying to solve with your next thing, and then you should deliver that through a sprint where you're really clear about what you want to do next, and you do that through a flat multidisciplinary team where you have the right kind of capabilities in that team, and that team is well facilitated by a scrum master in terms of the way you deliver the software. And as you have more and more things you want to do, you develop a product backlog, which you then deliver in a series of sprints in that kind of way. And that's the way we've been trying to develop things. And the reason why I call that out is actually I left Manchester today to try and get to London. I got as far as Stoke-on-Trent and turned around and came back because they cancelled all the trains. But I actually left a workshop with colleagues from Lilly on obesity, whereby in the room we had people from the life sciences industry, we had patient representation, we had people from the team that I work in, we had healthcare delivery people, we had pharmacy people, and so on and so forth. And one of the things that I said before I left that meeting is that everybody in this room has an equal voice. They have to have an equal voice. And then what that does is it brings a series of kind of capabilities and actually capacity to the party, which you could only dream of if you tried to do this stuff on your own. So if I look at all the things that I'm proud of that we're doing at the moment, it's all where we actually kind of creating those right kind of industry partnerships and using those industry partnerships to take us further than we would go on our own, and faster than we would go on our own, because some of the capabilities are things which we need to harvest. And I think key in that is that you can use the core 20+5 framework, which I think is a good framework and is a good one to use. But actually, I think everybody now has woken up to the fact that inequalities are there and they need to be tackled. And actually that plays into the kind of conversation as well. And some of the stuff that we've been doing with one of the big global pharma companies about deploying a novel medication at scale has been so unbelievably focused on trying to make sure that we address inequalities, not create greater inequalities. And of course, our pharma partners in that have been absolutely key as we build that stuff, that stuff up. I want to say two more brief things, if I may. The first is, this comes down to sort of cultural alignment, and cultural alignment comes down to relationships, having the right conversations with people. I mentioned this before, being clear about what people's motives, being clear about people's key performance indicators, respecting all those things and making all that stuff work is kind of, absolutely fundamental to this. And then the final thing I want to say is that I honestly don't spend my whole life going around having arguments with people, but I do have a few arguments along the way to try and get stuff done. And one of those things, which I'm kind of really quite sharp on, I think, is when people at levels within organizations or integrated care systems or whatever else question the wisdom of having the right kind of partnership with the life sciences industry. To which I will always say, you don't just, start working with everybody all the time about all the things, but find the people that you've got shared culture, shared process, find the companies who've got a really compelling product pipeline, which actually plays into the problems that you want to try and solve, and then try to craft those compelling partnerships and relationships with them where you can get stuff done faster, quicker than you would otherwise do on your own.
Thank you very much. And Jill, any final comments from you on this question?
Well, as you said, sum up. So I'll try and sum up. Integrated care systems have a requirement to address inequalities, and one of the recommendations in the report is that there should be a life sciences lead in the ICS, which hopefully will do. The aim of that is to do what Ben was describing, helping cement partnerships, and that should be across the board: research, diversity, bringing data to the notice of the ICS on inequalities, and importantly, of making sure that there is no inequalities in use of new technologies, because sadly there often is, and industry, life sciences might be able to help with training, pump priming, and making sure that innovation is taken to some of the more hard to reach communities, because there's good evidence that shows you need to do that. You need to go to where the challenges are.
You do need to take the mountain to mama, don't you? Yes, I agree. I'm going to speed us through the next three questions. The next one, I'm going to ask Laura to answer first, and then Jill, if you don't mind supplementing it, and then only if you the panelists have additional comments, I'll come back to you. So what role do you see pharmaceutical companies playing in innovation within the NHS over the next decade? And I'm just going to slightly link this to Mark Davis's question online. The original question was put by Anushka Ambrose, who's a consultant at Capgemini and is joining by Zoom. And Mark Davis is also online. And he wants to know about how can a truly authentic sense of partnership be created between the two sectors, given that there's some pejorative view about pharmaceutical industries and technology industries coming into partnership with the NHS. So I'll start with Laura first, if I may, and then go to Jill.
Thanks, Michael. So I think I would just state to start with that pharma companies and biotechs, by their nature in 2022, are large collaborative organizations that value research and are driven by data. And we work extensively with clinical research organization, contract research organizations, academics, clinicians. It's very much a team sport. I mean, just to give you an idea from sort of Lilly's pipeline, is that in the last 8 years, we've had 17 new medicines approved in a major market. And over 50% of those came externally. So, sort of external innovation and working collaboratively with scientists, with clinicians, with everyone who is involved in getting, essentially a scientific idea through to regulatory approval and market launch, is absolutely a team sport. We want to be strong partners with the NHS, clinical researchers in the UK, scientists, both basic and translational, and with the regulatory and approval bodies. Innovation approaches and methodologies are embedded at every stage of what we do within the life science industry, whether it's new quality methods for manufacturing, whether it's new AI, ML, computational chemistry methods, as you're taking, a drug through some of its, putting it through its early paces, and also the way we run clinical trials. But, that it's very much that innovation is part of everything that we do in that entire sort of life cycle of a product. And, it's not, but it's also about funding. It's about funding companies. It's about funding the funders who fund the companies. It's about the support through expertise that other people can leverage. And, what we're really looking to do is support, thousands of ideas and hundreds of companies so that the innovation that is out there has the support, the environment, and the talent in order to be that kind of bleeding edge science that will actually end up improving the lives of communities and helping patients. It's great that Ben mentioned a particular project that we've been working with on Health Innovation Manchester. And, that's replicated by, our oncology teams helping to sort of cut waiting times in cancer clinics and developing kind of forecasting models to kind of help clinical capacity. And also, I think during COVID, we also had a sort of collaborative telemedicine program as well, which was sort of my skin selfie. So these are all kind of individual things that we can do. And we really firmly believe that we can be part of the solution, but we also need to scale those learnings. So the successes in, Health Innovation Manchester should equally be, available for patients, beyond Manchester. And sort of scaling and learning at a national level is super important. Otherwise, it's too time consuming from the company end. How you have to be practical about this as well. And also, it's a huge duplication of effort at the care provider end, plus the obvious risks of inconsistency across sort of different regions. So creating these blueprints for improvement to be able to be truly scaled is super important. And, if these efforts aren't then adopted at the national level, it's very much just this sort of piecemeal approach. And we can't really take decades for this to work, because essentially patients up and down the country are waiting for this right now.
Thank you very much, Laura. Jill, you'll have seen massive change in your career, the relationship with industry. And do you think that's maturing and the trust has developed, and that perhaps the public are more reassured by it since COVID?
I think COVID was great at the public understanding more about science, understanding more about research, and seeing the benefits of that. It really was quite astounding how quickly things changed. But of course, alongside the greater trust and understanding, we also saw misinformation and mistrust, didn't we? So we always have to be cautious about that. But in my 20 years at NICE, I have seen some fantastic developments in terms of new drugs coming through, many for cancer, but other conditions too, like rheumatoid arthritis. And if you look forwards at the pipeline, there's clearly a lot that's going to change in relation to genomic technologies, more targeted treatments, new treatments for rare diseases, much more individualized care. And all of those mean we still need to pay attention to public trust and public understanding, because there is clearly some mistrust around anything that means you're going to have your genome mapped. What's going to happen to that data is always a question. But it takes me back to the need for there to be the life sciences partnership with the local healthcare system, because some of these new developments, these new innovations are going to change the pathways of care, and they're going to change the services that we need to have at a local level to get them through and to get them to patients. So we have to all work hard at getting these new treatments through to the population at the right price, putting my nice hat back on, and working together to make sure the systems are efficient and effective.
It always has to be the right price, Jill. We're all been there. I'm going to go to the next question now, because we're going to run out of time fairly soon. I'd like your help with this. It's put by Tom Mellor, Head of Private Health and Life Sciences at BJSS. And that's, what are your top 3 goals for the Commission in 2023? What can you direct us to look at that will be important over the next 12 months? Richard, I will start with you, and then go to Ben, and then think widely. We're open to persuasion.
Well, Mike, I think I must have shared one of my comments. I'll give you one because I know we're short of time, but I think because of the nature of the way we've met over the last year, which has been fantastic, we're all used to Zoom now, aren't we? I think we need to practice what we preach as a commission and think about how we can learn more from a wider geography. And so as we start to think about the topics we'll tackle next year, how can we look for more international comparisons and international partnerships? It's great being having a conversation with the UK, but actually technology now allows us to do so much more. So we need to import more learning, and we need to import more opportunities for partnerships. And this commission, I think, is well set up to be able to bring some very rich learning into the debate.
Thanks, Richard. Ben, you're holding your head in your hands. I'm not sure that's you're despairing about what we can do, but what would you say?
No, that's my thinking look. And it's a good question. And I was trying to think how to come at this and say something useful. I'll say what was going through my head. I'm not sure how useful it will be. But I can't remember who said sometimes I win, sometimes I learn. But I think it's quite a useful way of looking at this stuff. And we're trying to really take a use case approach to the things that we do, particularly around a lot of the digital stuff, actually, where we think, let's deliver this use case, but make sure we learn the lessons from them. And I wonder whether there's some stuff in this, and I know this is quite a difficult thing, but actually some of the things that we've all tried to do on our own or together and haven't really worked has enormous amounts of learning in them. And it doesn't always seem like the most kind of appropriate way to take some of these commission activities forward, but a real good look at juxtaposing something here which has worked and something here which wasn't worked, and really teasing out some of the lessons in that kind of that way may be an interesting thing to think through. But that was my thought with my head in my hands, and apologies if this isn't very smart.
Well, I think you're always smart, then. Don't worry about that. And I think it's very, very useful what you said. I'm just going to link this, because we're going to go 2 or 3 minutes left. So the final question is, how can we share more knowledge around best practice, be more open-minded to learn from others? And I'm going to link that slightly further into somebody called Walsh 11 online, who said, what might be on a list of Jeremy Hunt-style Edinburgh reforms for life sciences? And I'll ask Laura and Jill if they can think about those sort of areas, along with their sort of tips what we should be doing next year.
So I think back to really sort of key barriers around sort of national strategies and guidance for these ICSs. And, you know, we want to avoid gaps in sort of potential partnerships with the life science industry. And, you know, we have to kind of work out, you know, how we're willing to maximize that trust and also maximize the ability to kind of partner so that we can, you know, deliver things, you know, broadly and equally for patients here in the UK. I think just to pick up on the previous point around, you know, recommendations and the next roles for the Commission in 2023, you know, we do really value the work of the Commission here, and, you know, continuing to shine a light on these topics to sort of realise the UK as life science vision and designing strategies and implementation. I think I just pick up on one thing, which is, you know, the preamble was really around, you know, developing those key strands of policy and developing effective implementation strategies through the extensive research that's been done and continuing that research, and in order to see change at every level in the NHS. And I think next year, really, our hope is around, it's not just about effective implementation strategies, but it's actually getting down to the hard business of effective implementation. And, you know, that I think is, you know, I guess, you know, that is also how you end up also sharing knowledge and finding best practice by starting to implement and really doing the incredibly hard work that's required.
I think you're totally right. We do concentrate on that implementation. I think, Ben, you've said a bit about that earlier as well. Jill, a final word to you, and then we'll hand back to James.
Yes, well, learning from others, do once and share, I think, was a phrase that was coined, and it seems to make absolute sense, doesn't it? We share our examples, and there have been so many different databases, online stores of these examples over the years, but it seems to be quite difficult to share and make change happen in different places, and reasons for that have been described many times. You know, it's not made here, perhaps, that the problems are different in different locations, that they haven't been written up clearly enough, that they haven't been costed. Who knows? But it does seem to be quite difficult to do that, to do once and share, frustratingly so. However, that doesn't mean we should give up and not try to do it, but we should think about mechanisms to facilitate that. Perhaps sharing staff, because at the end of the day, it's all about the people, and people have to be enthused, people have to be convinced, and people have to make the change happen. So I suspect that's what it is about. It's less about writing it up and putting it on a database. It's actually getting people to work together and understand what's been done and how it worked for them.
Thanks for those final words of wisdom. And I think bring and borrow is a good idea. James, I'm going to leave you to close the meeting down, but thank everybody for their contribution. And over to you, James.
Thank you. Thanks, Mike. And my sincere thanks to Laura, Jill, Richard, and Ben for their contributions, for joining us. I'm just going to end, with 2 things. Firstly, again, to thank everybody involved in putting on not just tonight, but helping us with the report. And I hope you will enjoy it. I hope you've enjoyed and been stimulated by the discussion this evening. The second point is actually thinking ahead. We had a discussion with the advisory board at the end of last week about what subjects we might be thinking of lots of different points of view. Should we focus on disease areas? Should we focus on comorbidities? Should we focus on particular areas of science or research? I think what we've heard is we should also think about people, culture, and implementation. And we have tried to do that, but inevitably what we've done is we've written things down. And so I think probably that's a challenge for us in the Commission in 2023 to get on the road, to actually spend time in different locations and to think about what the things that we have proposed in this report and that we might propose in our next work can actually, how they can be done in real life so they create real impact, and we can point to them in years ahead and say, not only did we think that, we encouraged somebody to do it and it actually helped. Wouldn't that be a wonderful thing? So I'm going to sign off there. Thanks again to everybody for coming. Really do appreciate it. I can see the nibbles and drinks are served. I'll let everybody go online. Thank you for everyone who's joined us in the chat, the Q&A, our panelists, Laura for joining us in person. Have a lovely evening. And as I said earlier, this is a process, not an endpoint. So please do stay in touch and help us with this work. Thank you.